Thank you. So we undertook this phase 3 trial in order to respond to a personal question, I would say, and then I will explain why. So that shouldn't be there. Okay. So the background is that we already demonstrated against sham in a randomized controlled trial that the MR-guided focused ultrasound is very good in pain palliation. And observing also the results, we were not only good in palliation of the pain, that's VAS0 out there post-treatment, but also in getting some results into the lesion itself. And we were able to demonstrate further this in a study where we looked also to the local tumor control. Now, we undertook a two-center study prospectively enrolling patients with bone metastasis eligible for MR-guided focused ultrasound that they were randomly assigned to either focused ultrasound or radiation. Now, again, from a clinical point of view, we already had a clinical trial demonstrating the value of the focused ultrasound. The need for this specific trial probably did raise more from our side, because we were not able to convince somehow the radiation oncologists that the technology was mature enough to treat patients with bone metastasis. So we included patients into the two arms in a 1:1 ration assignment, and we did a comparison in 4 weeks, so 1 month follow-up as a first checkpoint, and we looked specifically to a reduction of at least 2 points in worst pain, and also stable or reduced opioid dose, which means quite large outcome scenario that we were looking at. And as you can see, we enrolled fairly similar group, and with all kind of primary cancer, and the result in clinical, the primary clinical endpoint was very equal actually between the radiotherapy and the MR-guided focused ultrasound. So in terms of pain reduction, again, 2-point scale is not that much, at least it's not what we expect to be a great result. But when you see specifically what happens when we look at the results, we perform much better in terms of the easiness of get rid of the pain with the MR-guided focused ultrasound. And specifically, when you look at these data, I'm sorry that I cannot point out, but you see that the complete responders were much higher, especially at 3 months, and also we kept constantly look at the patients over at least 6 months. And at 6 months, we still had patients with complete response that were in the range of 40% against 10% of the radiation therapy. And interestingly enough, we did not see that many deaths in our group compared to the group of radiation therapy. Now, those data are full of bias because this study, we did struggle a lot against radiation therapists. I mean, the real scenario that we face every day is just, let's say, a patient was randomized to undergo MR-guided focused ultrasound, but the time I organized the session for the treatment, the patient already got the radiation. So for them, it's much easier, and it's impossible to compete one-on-one against radiation at the moment. But we were able at least to generate these data, which are, to my eyes, very interesting at least. So, and there is also a good result in terms of survival. So we performed a little better than radiation therapy. Again, probably the reason for that is because we tend to get patients that were generally with a better shape, but this was not significantly different. So at the end, we need to assume that there is some effect that with radiation, with the side effects of radiation, that affects also the survival. Think that the majority of these patients got lesions into the pelvis, and so when you treat arms or legs, there is no problem for side effects in radiation. When you treat hip lesions, it starts to have the problem, especially in patients that were treated multiple times, receiving a lot of radiation on the same site, or especially when the lesion is quite diffuse. So this might be also one interest point to look at, especially in further study. This is one of our patients. As you can see, we did not only get a good pain result, but also bone mineralization. So in terms of palliative purpose, we actually acted even better than radiation. Now, how to present this data to the community is actually very, very difficult. I believe we will never publish some of this data if a radiation oncologist will revise our paper. But the point is also that we can treat these patients while they are under chemo, which is another interesting point from the oncological point of view. We need terribly this data, and we robustly need to demonstrate this data to convince people that are not sitting in this room, because I believe by this time of the day, we all are convinced that focused ultrasound for pain palliation, and not only, but in general for bone metastasis, is a very good technique and should be used as a first line. And if it doesn't succeed, or you have a lesion that's not accessible, go for radiation. Otherwise, spare radiation for future treatments that surely the patient will need. Thank you very much for your attention.
Maybe just one quick question.
Just one short comment that I think you should bring it to the attention of patient advocacy groups and create pressure from that side. But I want to ask whether you measure the amount of medication in both arms that people take, because what you showed means that people in radiation takes more medication in order to palliate the pain until the radiation kicks in.
Yeah, exactly, because the radiation actually seemed to work to get a real benefit, if it does, later on. So they kept abusing of drugs. You are totally correct. I mean, and this was measured again. I'm in a position where showing these results is okay in a friendly environment like this. Again, putting that into the literature will be difficult. So I'm terribly looking forward to also next studies and future studies that can actually demonstrate the same results.